Hello, and welcome to another session of learning orthodontics easily over a cup of coffee. Today is our fourth session. I'm Ji Dae-kyung, Orthodontic Barista Senior.
And I'm Lee Jongkuk, Orthodontic Barista Junior. In our last session, we discussed orthodontic approaches for saving wisdom teeth. This time, we'll continue with another saving story.
The final topic in our pulling and saving series is molar uprighting, orthodontic treatment to straighten tilted molars. Today's topic is an exciting one. But before diving in, it's time for our special tradition, brewing a cup of coffee.
Absolutely, good idea.
Shall I add a rhythm for you?
Let's try this.
1, 2, 3, 4.
커피 한 잔 할래요?
Fun fact is I was in the choir. For today's coffee, Orthodontic Barista recommends something to invigorate those feeling worn out, just like straightening tilted molars brings balance. It's the perfect cup to recharge your day. Today's coffee is Mazagran.
The name might sound unfamiliar, but Mazagran is a coffee originally from Portugal and is popularly enjoyed during the hot summer months. It includes a splash of lemon juice, giving it a refreshing tangy flavor. This zestiness helps beat the heat and energize your day, making it the perfect vitality coffee. First, let's start by adding the lemon juice. Looking at the recipe, what do you think? It seems like it'll be a bit tangy, but since I love sweet flavors, I'm going to add some sugar.
You're indulging in sweet Dalgona coffee and now adding more sweetness? I'll stick with the sour taste.
Oh, really? Don't regret it later.
Will it be too sour?
Then, I'll add 1 scoop of ice. Next, you'll need to fill the glass with ice and decorate it with a lemon slice. After that, pour in the sparkling water. I like the fizzing sound. Finally, add the espresso on top. It kind of feels like making a cocktail, doesn't it?
The way it spreads out is so pretty. It's exciting.
Shall we give it a taste now? It's surprisingly good.
It is really sour. Feels like water went up my nose.
It really is vitality coffee.
It definitely boosts your energy.
For those watching, enjoy a cup of coffee with us and recharge just like we're doing now.
This is so funny.
Alright, let's officially start Ji Dae-kyung and Lee Jongkuk, Easy Orthodontics.
For those watching on Denall, you can see the chat window on the right-hand side. Feel free to ask any questions related to today's topic in the chat. We'll do our best to answer them, and we'll also be giving away Starbucks coupons to selected participants through a draw.
Speaking of events, starting this month and for just 2 months, we have some special gifts to give away. For the best question, we'll be giving away a Vusen toothpaste and toothbrush set in collaboration with Music Tiger. So make sure to send in your best questions. Doesn't today's vitality coffee, Mazagran, pair perfectly with the tiger? Now, let's dive into today's topic, orthodontic treatment for uprighting tilted molars. You may have seen this topic in the literature. There are several factors to consider when uprighting molars. First, check if the third molars are present. Then, decide whether to push the crown distally or pull the root mesially. You'll also need to determine whether to allow extrusion or not, and don't forget to assess the periodontal condition. Let's take a look at a 1999 JADA study to explore this further. Most of the literature on uprighting focuses on the overarching principle of straightening molars. While the principle remains consistent, there are numerous ways to design treatment approaches. So, you can explore various designs for this purpose. A key tip when designing is to utilize multiple helices, ensuring the mesial part of the second molar is upright while the distal part undergoes intrusion. As much as possible, incorporating a tip-back bend into the design is common.
Those types of springs are often seen in textbooks, and during my residency, I tried making and placing them, but it was quite difficult in the oral cavity. If you insert it into the tube first, the rest of the spring ends up pressing down completely on the vestibule. At first, I didn't have the knack for it. What about you? It's quite tricky to place, isn't it?
There are some tips that might help. Since we need to activate it anyway, the same applies to intrusion arch wires. Personally, I prefer placing a cotton roll in the vestibule area first, then inserting the tube in the posterior region.
Allowing the activated wire to press down on the cotton.
Regarding the design, as I briefly mentioned earlier, if you look at the first, second, and third cases, you can see the deep consideration behind applying orthodontic forces as gently as possible. Later, we'll showcase a variety of creative appliance designs in our case presentations. I believe you'll be inspired to come up with your own innovative designs as well. Let's look at a few more examples. This one is from a 2007 study, and it also focuses on appliance designs for molar uprighting. The designs are quite similar overall. The main focus is that the anchorage is shifted to the anterior region. Even though it's just about uprighting a single seventh molar, I personally believe it's crucial to carefully check the occlusal relationship during every patient visit. As orthodontists, when I look at these designs, I always think about intrusion wires. They look almost identical, don't they? It's important to observe the vertical aspects of the anterior teeth, especially to avoid any surprises during treatment. This study is from KJO, a Korean journal. It focuses more on finding ways to expedite the treatment process than appliance design. So in this case, the approach involves using screws to apply traction. I think this method might be applicable when extracting wisdom teeth. The idea seems to involve performing a corticotomy around the seventh molar area to accelerate the process. According to the study, this approach does indeed speed up the treatment as intended. We'll discuss this further later on. Next, let's look at the uprighting method using mini screws. When applying uprighting force, the degree of tipping and the level of locking appear to influence the tip-back moment. Instead of getting caught up in complex terms like tip-back and moments, let's simplify it. If a tooth is too tilted, it's harder to upright it. So, you can first translate it backward, and then upright it as a one-step or two-step process. In the second case, we first perform translation and distalization, followed by the use of an uprighting spring. This was a case I worked on.
I'm not familiar with this. Is that a scan of a film? It's been such a long time since I've seen one.
And it's not easy to find. I'm embarrassed to admit it.
Even after 18 years in the field. Looking at these cases with you makes me feel like a beginner again.
You are much younger. Back then, I used a microimplant to pull the molar backward, which is quite a simple and straightforward method.
The screw is here, right? How do you usually remove it?
I'm not sure if this will be helpful, but in some cases, screws do not come out easily with a hemistart. However, there are instances where they're difficult to remove. In such cases, I use one of our orthodontic pliers. A thin beak-how plier or a hook-shaped utility plier works well. At first, it can be a bit labor-intensive. You might need to remove it incrementally, about 10 degrees at a time. It's unavoidable.
We spend a lot of time learning how to place things like brackets, but no one really teaches us how to debond. Honestly, it's something we take for granted, but people who are new to this often find it very intriguing.
Anyway, moving on to another case from back in the day. As you can see, the 7th molar is significantly tilted. The degree of tipping isn't small. As mentioned earlier, this can be considered a form of translation. The molar was pulled slightly backward, and helices were used. At the time, it was right after my residency and during the early stages of opening my practice. I remember having fewer patients, so I spent a lot of time looping wires and experimenting.
Is that a kangaroo wire by any chance?
Do you know about kangaroo wires?
During my residency, my professor primarily used kangaroo wires. Did you know they've been discontinued? They're no longer available now. Someone asked us to find them, and we tried, but they're out of production now.
These days, we occasionally make springs using SS wires and heat treat them with a torch. Since you keep mentioning it, you feel unfamiliar to me.
It's been so long since I've seen them. Let me explain something here. If you look at this photo, you can see that open coils tend to slip out easily. When you need the wire to move backward, you have to extend it to allow for proper placement. Patients often come back complaining about wires slipping or poking them, so I make adjustments to account for this.
I extend the wire length slightly and perform cinching to secure it properly. Let's get started with today's case.
This patient has their 4th teeth on both sides but is missing the 5th and 6th teeth. We'll skip over the diagnostic details and go straight to the results. This is how the treatment turned out. If you've seen episodes 1, 2, and 3, you'll notice that cases often take around 3 years. I have to be honest about this because if I only show successful or quick cases, it could give a false impression. This particular treatment took quite a long time, 48 months to complete. The patient is a young male. This patient said he would never undergo orthodontic treatment again. It is uprighting case that also involved protraction. The goal was to place just one implant and manage the rest by pulling the teeth. What I want to highlight is that the alveolar bone on the mesial side remained relatively well preserved during the process. The next case is quite similar to the one mentioned earlier. While the missing teeth differ slightly, the overall pattern is comparable. In this case, the 7th and 8th molars are tilted, and the 6th molar is missing. If you look closely, the alveolar bone level, even after uprighting, didn't seem likely to follow the uprighting movement. My concern was whether the bone would further sink later. However, even with an implant, the lowered bone level had already become an issue. The patient complained that food frequently gets stuck in the teeth in the 3rd quadrant. I didn't think orthodontic treatment alone would resolve that issue. I didn't think placing an implant would fully resolve the issue either. I'm not sure what others might think, but in this case, we decided to proceed with orthodontic treatment. The patient was also quite eager to explore this option. We carefully performed uprighting and protraction. While the bone level doesn't seem to present a severe issue, it hasn't significantly risen either. In fact, it might have slightly lowered. This isn't a showcase of a perfectly successful case, but rather one that involved a lot of deliberation. I'm still uncertain about how the long-term management will proceed. The patient, however, is currently very satisfied with the current results, even though the treatment isn't fully complete yet. I brought up this case under the theme of uprighting.
In cases of bone defects, one of the periodontal treatment goals is to align the bone level evenly. With uprighting, we sometimes achieve effects similar to distraction osteogenesis, where bone is pulled upward to increase the bone level. In this case, while the bone level seems to have slightly lowered, it doesn't appear to show significant defects. So, perhaps the periodontal treatment helped maintain the bone level afterward.
While periodontal treatment is necessary as part of the treatment, it's not as though the bone suddenly collapsed or significant bone regeneration occurs. This is my first time using this magic pen, and I can't stop doodling with it.
Is this part of the concept, the back in my day versus your time theme? Seniors like me only got paper, while juniors get magic pens. I'm a bit envious now.
Let's grab a coffee and continue. This is a very basic example, but if you look back at episodes 1, 2, and 3, you might wonder, isn't it the case of pull that tooth as well? But I didn't just pull teeth. It was all done after discussing with the patient.
Which is a good thing.
This patient is a young male, and I thought it might take over 2 years to pull these teeth. So instead, we opted for extraction and uprighting. Of course, I typically plan for a duration of about 6 to 12 months for uprighting. If you look here, there seem to be many devices available for creating space.
This is essentially partial orthodontics.
There's a very simple device called the Easy Spacer, but since I primarily focus on orthodontics, I ended up using brackets. This could be seen as either an advantage or a disadvantage, depending on the perspective. Here, I used a screw to establish an indirect anchor. When pulling from the buccal side, you'll notice rotation occurs like this. This pen is excellent for explaining such concepts. It's been really helpful, especially with the topics. So what happened in the case is that buccal rotation occurs. Depending on the situation, it may also be necessary to approach from the lingual side. I hope you keep that in mind. That's why I chose to present this case. I think transitions as shown here are probably the most common. Of course, there are various options, such as using protraction to revive the tooth.
It is similar to the approaches we discussed previously.
It's good to be aware of these approaches options available. In my experience, the most common cases I've encountered involve mandibular molars that simply tilt, while maxillary molars tend to rotate mesially and tilt inward. Cases like these can actually be quite manageable. This is a relatively favorable case since expanding the space allows for some recovery. I'm sharing cases I've encountered, where partial orthodontics were used to straighten the teeth. The anchor part remains securely connected, so it doesn't deviate much. By gently using an open coil spring, sufficient space for implants can be created. Here's another case, similar to the previous one. It involves partial orthodontics for the anterior teeth.
Why does this feel so reassuring? It's probably because we're using implants.
In situations like this, where there aren't many other options, an implant often becomes a reliable solution. I wanted to share these cases with you. This particular case references a 2014 study. I had seen it in several lectures before, and it made me question whether the methods I'd been using were perhaps too aggressive. We use various wires for uprighting. But after reading this paper, I realized that even light wires could effectively achieve uprighting, something I had overlooked. As you can see, this wire was set up in advance on the cast model.
The wire is pre-made to align with the setup.
mimicking the conditions in the actual oral cavity, where the tooth would be tilted. The wire is then bent and placed accordingly. By doing this, the uprighting process works effectively, resulting in a well-aligned tooth. That's the key takeaway here.
In a way, it's so straightforward that it almost doesn't need explaining. The theory and principles are clear, and the treatment results are simple yet precise. Interestingly, among the multiple authors of that paper, one name particularly stands out to me. I wonder if I could get in touch with them. Oh, do you think that's possible? Yes, I heard she is currently in the US. Shall we try to connect with her?
A live call to the US at this time?
Professor Kim Min-ji, are you there? Hello. It's great to see you again. It's been a year. Could you please introduce yourself briefly for our viewers first?
Hello. My name is Kim Min-ji, and I work in the orthodontics department at Ewha Mokdong Hospital. Currently, I'm on an overseas research fellowship at Ohio State University. I'll be conducting research here for a year. I will return soon.
It is impressive.
And it is great to have you with us. Thank you so much for joining us for this interview. Let's start with our first question.
We're currently discussing the topic of molar uprighting. Professor Kim, you are personally my mentor. You were my professor during my university residency and played a big role in shaping my career. Regarding molar uprighting, many studies demonstrate that even with very light forces, such as using weak 9-tie wires, teeth move remarkably well in situations where movement might seem unlikely. Is this a method you still frequently use?
I'm currently applying this method to all molar uprighting cases. Surprisingly, we've been using much stronger forces than necessary. We learned from textbooks that molar uprighting can be achieved with very light forces. Now, we're using even lighter forces than what was described in the studies at the time. It's likely that the forces we currently apply are even gentler than those used in the papers.
Before connecting with you, we discussed various loop and helix appliance designs that we routinely use in the clinic. This approach is quite simple and straightforward. But are there any concerns during treatment, such as buccolingual stability, vertical stability, and TFO?
Using very light forces might reduce the likelihood of TFO. But of course, some degree of TFO is inevitable during uprighting. The severity seems significantly reduced in these cases.
Yes, even with a buccal-only approach, we can achieve quite good results.
In some cases, we combine it with a lingual approach as well.
When the uprighting distance is significant or distalization is required, we sometimes use both buccal and lingual approaches. If rotation is necessary, we might use a lingual attachment instead of a buccal one. It really depends on the situation, and we adapt accordingly.
So, do you generally use this method even in cases with significant tilting, unless there are specific contraindications?
Exactly. This method is highly adaptable, since the bonding position isn't restricted to the bracket placement. You can bond it anywhere suitable, even while checking the bite. This makes the application range very broad.
You mentioned using light wire sizes. What size do you typically use?
We usually use 012 nickel titanium wires for molar uprighting, but we don't go beyond 016. Most cases are completed with 014. Occasionally, when there is significant TFO, nickel titanium wires can fracture. In such cases, we use slightly thicker wires with smaller activations.
Professor Kim, as a final note, what advice would you give to dental practitioners watching this who want to replicate this design?
We usually begin by setting up the model to design the uprighting and determine the amount of movement needed. However, in cases with excessive tilting or when the amount of movement required is too great, it can still be challenging. In such cases, we start by gently pushing the tooth and then retake an impression to properly set up the model, program the movements, and apply the wire accordingly. When first applying the wire, there are instances where the crown is only partially exposed. In those situations, we don't program 100% of the movements from the beginning. Instead, we upright the tooth to a certain degree and then proceeding further.
Thank you so much. You'll return in June or July, right? We'll treat you to a big meal. Until then, stay safe, and let's hope the situation with COVID improves. Thank you again.
And we'll see you soon.
Now, let's move on to the next case.
Let's quickly go through this. Typically, this is the kind of design where a firm wire is used with an open coil to push the tooth backward. This was referenced in one of the papers we looked at earlier, cases where the goal is simply to push it backward. There are so many designs available, as we mentioned earlier, including approaches where you push the tooth backward and then upright it. This was a case I worked on during my residency. It's essentially the same, you push the tooth backward and then upright it. Of course, during uprighting, it's challenging to completely avoid extrusive movement. Of course, there are many designs that can prevent this. But to explain it simply, we use this type of wire. What kind of wire is it? And what role does it play? Initially, I used TMA, but now I'm using SS wires. It's essentially the same as an uprighting spring, but with an added feature to attach elastics. By doing so, it presses down on the vestibule, and we forcibly lift it upward. By lifting it like this, it creates a tip-back effect. If you look here, I attached elastics between this screw and the front part. When the elastics are applied, both uprighting and distal movement occurs simultaneously. This design was devised to achieve uprighting while creating space, and it worked as intended. This was back in 2007 when I was in my second year of residency. It was a time when there was a lot of trial and error with such methods. There are a variety of designs available. Let me show you a recent case where I applied one of these designs. These kinds of cases are more common than you might think. You see them, right? Quite a lot. However, comprehensive orthodontics might not be ideal for such cases, so I wondered if partial orthodontics could be a solution. While there are many design options, here's an example. By connecting a power chain or elastics here, it generates distal force. When applied intraorally in an activated state, lifting it and hooking it in place creates a tip-back effect. By combining these two principles, as you can see, this design worked out well in this case. To refine the occlusal detailing, we used the previously placed screw as an indirect anchor and connected it with a wire for added precision. As you can see here, the space created allowed us to focus on this section with partial orthodontics. It turned out to be a relatively successful case.
In the past, for cases like this, we would have had to transfer the anchorage to the anterior teeth, as in the earlier design. This meant carefully explaining the possibility of full orthodontics to the patient. With screws now being more widely used, occlusal condition should be observed and concerns about anchorage stability have significantly decreased.
Although there are many papers on the subject, having 2 screws can help control extrusive forces more effectively, even if not perfectly. Using 2 screws allows for better application of both uprighting and slightly intrusive forces, as opposed to the challenges of using just 1 screw.
Reflecting on the earlier phone interview, I've realized that the more I think about design complexities, the more I feel we should aim for simplicity in our approaches.
That's correct. Keeping it simple is best. Let's move on. For cases where the tooth is tilted lingually rather than forward, the most basic approach is to insert a 016/022 auxiliary nickel titanium wire, commonly referred to as erect wire, to help rectify the alignment. Using erect wire helps align the teeth neatly. In cases where an auxiliary wire is needed for additional distal movement, resin is applied to create anchor points for elastics. Resin is first applied to the anterior region to attach elastics, and then additional resin is applied at the necessary points for elastic application. This setup facilitates distal movement, allowing the tooth to move backward along with others. It's a versatile method often utilized. If the tilt is more pronounced, there are several options. One approach is to place a screw on the buccal side to pull the tooth. While placing 2 screws ensures parallel movement, in cases where the tooth is tilted mesially.
A single screw can still provide vertical control and other advantages.
In some situations, the wisdom tooth needs to be extracted anyway. As I mentioned when the patient was under anesthesia for wisdom tooth extraction, we opted for the quickest possible method as the patient had limited time in Korea. This patient resides abroad. And here you can see the results at 2 and 5 months. The tooth continued to show progress, reaching this stage by the 8th month. At that point, we had to stop as the patient needed to return to the US. We finalized the case with sufficient contact with the maxilla.
What did you all think of this case? I've shared various principles for molar uprighting, along with numerous appliance designs and ideas we've explored together. That said, it's a bit bittersweet when reflecting on Professor Kim Mingju's interview. It all wrapped up so simply that I'm left wondering if we even had enough content to fill 30 minutes. Nonetheless, I want to take this opportunity to sincerely thank Professor Kim again. Wishing everyone a refreshing and energetic afternoon. We, your sweet and charming hosts at Ortho Barista, look forward to seeing you again soon. Thank you for watching.